We're ready,
Yes, sir.
Tanisha. Okay, let's call the roll, if you would, please, Tanisha, and make sure everybody on the board can mute and unmute as we start the meeting. Go ahead, Tanisha.
Thank you. Norman Boyd,
Here.
Roger Folsom,
Here.
Russell Crutchfield,
Here.
David Cruz,
Here.
Mark Trell,
I'm here.
Kenneth Davis, Kenneth Davis.
Here.
Thank you. And Mr. Davis, you may have more than one microphone on. If you have, for instance, your cell phone and your audio on your computer, it's going to give feedback. I'll move forward. Anthony Williamson,
Here.
Russ Childers.
Here.
Chairman, that concludes my roll call.
Thank you, Tanisha. Thank the board members for being on this morning. We have a pretty full agenda today. We have a quorum and all board members are present. This morning, we're going to something different and thank the staff here at DCH. The presenters will be on site here at the meeting room, and hopefully we get around some of the audio issues that we had last time. So appreciate those folks being here. At this time, I'll call the meeting to order. And the first agenda item, we will be going through the agenda today. We have about 5 areas that we ask for votes for final approvals and 2 initial approval items. But the first thing is the minutes of the August 12th board meeting. And I'll turn it over to our secretary, Russell Crutchfield, and ask if he has read those minutes and can make a motion for approval.
Well, good morning, Mr. Chairman. I have reviewed the August 12th board meeting minutes and I have found them to be correct and in order. And I move that we approve the August 12th, 2021 board meeting minutes.
I've heard a motion for approval. Is there a second to that motion?
Roger Folsom, second, Mr. Chairman.
Roger Folsom has seconded that motion. All in favor, say aye.
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 Opposed? Abstaining? Hearing none, the minutes are approved, and thank you very much, Russell. I'll move next to a committee report on the audit from the audit committee chairman, Russ Childers. Mr. Childers, would you please proceed?
Took me a minute to get unmuted, Mr. Chairman. Sorry. We did have an audit committee meeting this morning. We received the report of the auditors. Everything seemed to be in order. It was a very complete report. Don't think we have any issues or questions with the audit.
Okay, are there any questions or comments from board members, please? I think we all received in advance the copy of the presentation that the committee was going to receive. And so if anyone has any questions, or please mention those at this time. Hearing none, thank you, Mr. Childers, for your committee report. Next, I will turn it over to Commissioner Noggle for her report.
Thank you. Good morning, Mr. Chairman. Good morning, members of the board. First, I want to just comment on COVID a little bit. Department of Community Health is currently serving really as ground zero and incident command for a coordinated state operational response, really under the direction of our Deputy Commissioner Ryan Loke, who formerly served as the governor's chief health policy advisor. So we continue to work on that. One of the main things that DCH has been involved in for many, many months is staffing augmentation, recruitment, and financing around the state. Our Chief Compliance and Technology Officer, Joe Hood, continues to lead that effort for us. We are working very diligently to recruit and fill about 2,800 approved positions around the state. We've got about 1,400 of those filled and have those staff, contract staff, nurses, and staff working at about 71 hospitals and facilities statewide. We continue to work on filling the other 1,580 or so positions. We continue to get requests every day. It's getting increasingly challenging to recruit those contract nurses and physicians and other medical and clinical personnel to come and work for us, just as the competition heats up amongst the states. But that's something that we're also trying to address from a policy level at the federal level. The governor also authorized up to, I believe, 2,000 National Guardsmen on active duty, or 2,500. We've got about 180 deployed right now. About 105 of those are actually medical professionals with clinical training and experience working in a clinical setting. We've augmented those with another 100 or so that are helping in general purpose areas. We can continue to call on additional guardsmen as we get requests if we need to, but we're also trying to be a little bit judicious in that, knowing that the Guard is spread pretty thin right now. We're grateful for their service, but they've also, we continue to have service members stationed at the border, as well as that have been activated and deployed to Louisiana to help in hurricane disaster recovery there. But we'll continue to review those requests and allocate resources as we can. Bit of good news, hospitalizations have been down, about 100 or so hospitalizations in the last day or so. So that's a bit of good news, and we're hopeful that that holds. And you may have heard that the governor announced last week that we made a change to the state health benefit plan wellness program to incent vaccination among its members. The current wellness program awards points up to a maximum of 480 for members to complete certain positive, healthy activities, such as getting their biometric screening, participating in coaching calls, or recording physical activities. The vaccination activity will immediately reward someone with a full value of 480 points that member can either use to offset eligible medical expenses, or they can trade those points in for a $150 gift card. So our data right now shows that the vaccination rate among state employees is a little bit low, but it's also underreported because of so many which is positive, so many ways to get a vaccine around the state, but not all of them even require insurance. So in those instances, we don't necessarily know, but we're hopeful that this will continue to encourage state employees as well as public school teachers and personnel to get a vaccine. A couple of other agency notes. We kicked off our RFP design work in advance of the CMO re-procurement that will be coming up in the next year or so. This initial phase of work will focus on ways to include innovation, quality, partnership, and a focus on care coordination and healthy outcomes into the basis of that procurement as we move forward. We've also kicked off a short-term project to review the CMO mid-year 2021 rates. I'm sure, as you know, we work annually with our actuarial firm Guidehouse to set the base and mid-year capitation rates for the managed care program. As a result of COVID-19 and the volatility that we saw in the healthcare industry and that they all experienced, CMS encouraged states to consider risk corridors and other mid-year adjustments to take into account those COVID-19 impacts. The 2021 mid-year draft rates calculated by Guidehouse included a range of rates, but they were pretty significant reductions. So as I stepped into this role, it was important for me to make sure that the department had adequately considered kind of all sides and all data, both from Guidehouse and our CMO partners, as well as to look at kind of nationally what the norm was and how other states are calculating those mid-year rates. So we should have some feedback from our partner in that project within the next 4 to 6 weeks that I'll be able to use as we finalize what those rates will be that we submit to CMS for final approval, and we'll keep you posted. Speaking of CMS, we've actually started to see some movement on and approval of several of the pending items that have been outstanding with CMS for quite some time. I actually called and spoke to them last week, encouraged them to expedite some of those, as that we know, especially our nursing home partners are really dependent on some of those upper payment limits. And I'm pleased to report that we actually got that approval yesterday. It'll take a couple of weeks for those to get queued up and dispersed out to those eligible nursing homes, but really probably the timing couldn't get better. I actually joined the governor earlier this week in a roundtable with some facilities that continue to share the challenges and financial struggles that they're facing right now. So happy that we could do that, and hopefully we'll get those funds out pretty quickly. And just finally, before I wrap up, you know, I know everyone knows that this is a time when staffing and workforce challenges are pervasive across so many industries. And state government is not immune. We certainly have our own. So I just wanted to take a moment and recognize some employee milestones that we experienced as a department in August, and just share those with you and celebrate and congratulate our employees that have hit these milestones. Deborah Herring, Gladys Paul, Malcolm Wells, Donna Lee, and Sharon Bird are all celebrating 5 years with the department and state service. Latanda, and I'm going to mess up a name, Oladapo, Catherine Bradfield, and Keisha Holloway are all celebrating 10 years of service with the department. And Tijuana Wright is celebrating 15 years with this department and the state. So thank you to those employees for being here and for sticking with us, especially through the challenging times of COVID. Happy to answer any questions that you or any of the members of the board may have, Chairman.
Thank you, Commissioner, for that comprehensive report. And are there any questions for the Commissioner from the board? Any comments? Thank you very much. And hearing none, we will move into our first agenda item that will require us to consider a final adoption vote. And this is on a medical assistance plans for the state plan amendment to increase supplemental quality incentive payments to eligible nursing facilities. And Lynette Rhodes, Executive Director, Medical Assistance Plan, will make a presentation. Thank you, Lynette. Go ahead, and thank you for being here.
Good morning. Thank you, Chairman Boyd. Good morning, Commissioner and members of the board. Thank you for this opportunity to present. Pending final adoption from the board and approval from the Centers for Medicare and Medicaid Services, DCH proposes to implement additional quality incentives that will encourage Georgia's nursing facilities to improve performance in at least one of the following 4 categories. The first category is high-risk long-stay residents with pressure ulcers. The second category is long-stay residents who received an anti-anxiety or hypnotic medication. The third category is long-stay residents who received an antipsychotic medication. And the fourth category is long-stay residents with a urinary tract infection. As indicated during the August 12th board meeting, the supplemental payment will be based on the percentage of improvement ranked by decile for each of the 4 categories. Supplemental payments will be distributed to eligible nursing facilities twice per year. However, in year 1, which is state fiscal year 2022, eligible nursing facilities will only receive 1 payment. An opportunity for public comment was held on August the 19th, 2021 at 10:30 a.m. via WebEx. Written comments were due on August the 26th, 2021. We did not receive any verbal or oral comments. We did, however, receive 1 written comment. That comment was received from Donna Knackers, the Vice President of Reimbursement with the Georgia Healthcare Association. The following is a summary of the comments that we received from the Georgia Healthcare Association. The first is a recommendation was made that the proposed methodology be revised as it fails to reward providers who are already reaching and exceeding the quality measures and standards. In response, the department states as follows. The existing quality incentive program rewards providers who are already reaching and exceeding the quality measures and standards. For example, effective August the 14th of 2020, an additional 1% incentive can be earned by a facility that is an active American Healthcare Association Silver Award-winning center. An additional 2% incentive can be earned by a facility that is an active AHCA Gold Award-winning center. And a nursing center which is earned and is currently accredited as a Joint Commission accredited nursing care center will earn an additional incentive equal to 2%. Further, American Healthcare Association Active Bronze Quality Award winners will receive an additional point in the non-clinical measures category. The new proposed incentives are intended to encourage improvement and award those which demonstrate improvement in the specific targeted categories previously described. I will pause for any questions from the board.
Are questions or comments from the board, please?
Yes, Mr. Chairman, this is Mr. Trail.
Go ahead.
If I could ask, just for clarification, So if a facility meets the improvement goal, and, assuming it's like okay, I've improved, I met the goal, they'll receive just one payment and not ongoing payment for that goal, or do they then have to move up to these other criteria that you said in order to get the additional incentive payments?
So there are, I guess as a starting point, there are two portions to the quality incentive program. So the first, an existing portion of the program allows you to earn incentives for things such as staffing or meeting staffing metrics, also meeting certain clinical and non-clinical measures. So providers today or nursing facilities today receive those rewards ongoing. And that's based upon information that is self-reported. For this particular portion, they are eligible to receive the rewards twice per year. And each year we will adjust the base level requirement or metric. And then the following year, they will be required to meet the new standard. So each year, as the model is currently designed, we will make adjustments to the base level, and then providers will have to exceed the new base level. If they exceed the new base level, then they are potentially eligible to receive 2 payments per year. I hope that answers the question.
Thank you, Ms. Rhodes. That is helpful. If I might.
That answer your question, Mark?
That is helpful. So the ongoing ones you were referring to, those are pretty much the ones we've had in effect for a decade or more.
Yes, sir.
Okay, thank you very much. I yield, Mr. Chairman.
Okay. Any other questions or comments for Lynette? Hearing none, is there a motion for approval for final adoption?
I'm sorry, Chairman Boyd, I've got some more comments.
Oh, go ahead.
Sorry, so that was just the first comment from first recommendation from the Georgia Healthcare Association.
Please.
There are actually 4.
Go ahead.
So I'll move to item number 2.
Excuse me.
A recommendation was made to allocate a portion of the available funding as an incentive for achievement of quality for each of the 4 identified categories. The commenter recommended that DCH set a specific standard for each category, for example, the national average, and use that standard to measure the achievement incentive. In response, the department states as follows. Once the proposed changes are implemented, the department will monitor and review the data on an ongoing basis to determine if the proposed changes lead to improvement and a positive impact on member outcomes. The department will reevaluate the program changes and the model at a later date to determine if further modifications and interventions are needed. I will pause for questions from the board regarding the second recommendation.
Questions or comments? Hearing none, you may proceed to the third.
Okay, thank you. A recommendation was made to maintain the initial base period to measure improvement. The commenter indicated that adjusting the base period annually is potentially problematic and will create inconsistent funding for providers earning incentives 1 year and not the following year, even when they have demonstrated improvement and sustained improvement over the initial base period. Further, adjusting the base period annually will result in a reduction in the pool of eligible facilities over time, thus creating a larger incentive payment to a smaller group of providers. In response, the department states as follows, and this is similar to our previous comments. Once the proposed changes are implemented, the department will monitor and review the data on an ongoing basis. We will reevaluate the program changes and the model at a later date to determine if further modifications and interventions are needed. I will pause, Chairman Boyd, for any questions.
Any questions for Lynette or comments? Hearing none, proceed.
Okay, and this is the last recommendation, Chairman. Recommendation was made to allocate a larger portion of available funding annually as an incentive for achievement of quality for each of the 4 categories. should DCH choose to update the base period for evaluation of improvement. Per the commenter, this avoids the issue of funding being provided, then eliminated potentially year after year, even when the facility has sustained the improvement over the base period. This also ensures the proper balance and the distribution of quality incentive funding in subsequent annual periods. In response, the department states as previously noted, we will monitor and review the data on an ongoing basis. We will reevaluate the program and the model at a later date to determine if further modifications and interventions are needed. We'll pause for questions, Chairman Boyd, and that is the last recommendation.
Any questions, comments? I have one question, Lynette.
Yes.
Obviously, our objective here with this is to improve quality.
Yes, sir.
And it's probably in your financial analysis, but what percent of our nursing facilities would you anticipate that will reach these levels?
So these are really new targets, Chairman Boyd, where today we rank below the national average. So we're projecting approximately 50% should be able to meet at least one category, hopefully more, but we will have to wait to see what the results show.
Okay, and then obviously ongoing, we would hope to reach other levels
Yes,
of
sir.
improved quality, and this is the reason for the program, is that right?
That is correct. And that's also the reason why we are proposing to adjust the base level each year so that the nursing facilities can continue to improve, and hopefully we will meet or exceed the national average.
Thank you. Hearing no, are there any other questions or comments from the board? Hearing none is, do I hear a motion for approval for final adoption?
Folsom, motion for final adoption, Mr. Chairman.
Yeah, Roger Folsom has made the motion for final adoption. Is there a second?
Russell
Russ,
Crutchfield.
Russell Crutchfield has seconded the motion. All in favor, say aye.
Aye. Aye.
Opposed? Abstaining? Hearing none, it is approved. Thank you, Lynette.
Thank you.
Next on our agenda in medical assistance plan, the state plan amendment for portable radiographic and accredited mobile imaging service rates change. And Brian Dowd will make that presentation. Brian, please proceed.
Thank you, Mr. Chairman, Commissioner, members of the board. Today, I'm presenting for final adoption a rate methodology change for portable radiography and accredited mobile imaging services specific to Medicare crossover claims. At the August board meeting, Executive Director Rhodes presented a proposed change in the rate methodology specific to Medicare crossover claims for portable radiography and accredited mobile imaging services. This was in accordance with House Bill 81, which is the fiscal year 2022 Appropriations Act. Pending CMS approval and board final adoption, DCH will modify the rate methodology for portable radiography and accredited mobile imaging services from a flat max fee rate of $109.77 per trip to 100% of the Medicare reimbursement rate. An opportunity for public comment on the proposed change was held on August 18th, 2021 at 11:30 a.m. via WebEx audio. Written comments were due on or before August 25th, 2021. DCH received no oral comments or written comments on the proposed change. If you have questions, I would be happy to answer them at this time and will respectfully request your final adoption of the rate methodology change for portable radiography and accredited mobile imaging services.
Are any questions or comments? Hearing none, is there a motion for approval for final adoption?
Trail will so move.
I'm sorry, I think, Mr. Trail, you made the motion.
Yes, that is correct.
Is there a second to that?
Second, Williamson.
Yeah, Anthony Williamson has seconded that motion. All in favor, say aye.
Aye.
Opposed? Abstaining? Hearing none, it is approved. Thank you, Brian. Thank you for being here.
Thank you, Mr. Chairman.
Next, we'll turn it over to Kim Morris. She has 3 items to present. And you may proceed, Kim. She's Director of Reimbursement for Financial Management, and she has 2 for final adoption, and 1 will be asked for initial adoption.
Good
Please
morning,
proceed.
Chairman, Board, Commissioner Nago, and members of the DCH Board. Today, I'm presenting for final adoption a proposal to modify the average commercial rate calculation and frequency of data collection used to calculate the ambulance supplemental payment with an effective date of August 13, 2021. Total cost for this change is $20,333. State funds would be through IGT. The state will modify the state plan amendment to apply a medium state rate per HCPC code in lieu of commercial rates for providers who cannot provide at least 3 commercial payer rates. We would also allow ambulance providers to submit commercial rates every 2 years instead of twice a year. An opportunity for public comment was held on August the 17th, 2021 at 11 a.m. via WebEx. Written comments were due by August the 24th, 2021. We did not receive any oral or written comments. At this time, I will pause to see if there are any questions.
Any questions or comments from the board, please? Hearing none, is there a motion for approval for final adoption?
Russ, so moved.
Mr. Childers has made the motion for final adoption. Is there a second?
Second, David Cruz.
Mr. Cruz has seconded that motion. All in favor, say aye.
Aye.
Opposed? Abstaining? Hearing none, it is approved. Kim, you may move to your next item.
Okay, presenting for final adoption, a request to remove the provision that prohibits a physician from receiving supplemental payments through the Physician Upper Payment Limit Program and the enhanced primary care reimbursement rates simultaneously. Total cost for this program is $64,968,305. Removal of this provision will allow eligible physicians to participate in and receive both the upper payment limit supplemental payment payment and the enhanced primary care rate increase beginning October 1st, 2021. An opportunity for public comments was held on August 18th, 2020 at 10 a.m. via WebEx. Written comments were due by August 25th, 2021. We did not have any oral comments. We did receive 3 written comments. Those written comments were from Lisa Perry Gelks, medical MD, FACS, President, Medical Association of Georgia, Julie Bahavi, Chief Financial Officer of Colloquy Regional Medical Center, Jonathan S. Lewin, MD, FACR, Executive Vice President for Health Affairs, Executive Director, Woodruff Health Science Center, and Chairman of the Board, Emory Healthcare. Following is a summary of the comments received. Respondents expressed support for the Medicaid State Plan Amendment for the Physician Upper Payment Limit Program. DCH response was, "Thank you for your support." At this time, I will pause to see if there are any questions.
Any questions or comments? Hearing none, is there a motion for approval for final adoption?
Folsom, motion for approval.
Mr. Folsom has made the motion for final approval. Is there a second?
Russell Crutchfield will second.
Mr. Crutchfield has seconded. All in favor, say aye.
Aye.
Opposed? Abstaining? Hearing none, it is approved. Kim, thank you, and you may proceed to your next item.
Presenting for initial adoption, a proposal to revise the definition of individuals eligible for inclusion in the disproportionate share hospital calculations for uncompensated care as required by the Consolidated Appropriations Act of 2021. The act limits the individuals to those where Medicare is the primary payer for Medicaid assistance and the uninsured. This change eliminates individuals where Medicaid is the secondary payer. The revised definition will not impact the state's total dish funds. It would basically impact the calculations. I will pause now to see if there are any questions.
Any questions, comments from the board, please? Hearing none, is there a motion for approval for initial adoption?
Russ so moves.
Mr. Childers has moved for approval of initial adoption. Is there a second?
Second, David Cruz.
David Cruz has seconded that motion. All in favor, say aye.
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 Opposed? Abstaining? Hearing none, it is approved, and thank you very much.
Thank you.
Thank you for being here, Kim. Last agenda item that we have is the rules and regulations for Georgia Caregiver Registry. And Nigel Lang, our Deputy Inspector General, will make that presentation.
Thank you, Chairman Boyd. Good morning, Commissioner Noggle, members of the board. The Georgia Caregiver Registry rule is being presented today for initial adoption to comply with the provisions of Senate Bill 406 from the 2018 legislative session. This rule will allow DCH to create and maintain the Georgia Caregiver Registry. The law became effective on October the 1st, 2019. This is actually the second time this is being presented for initial adoption. It was presented in June of this year. There was an administrative oversight after the initial adoption vote and then the public hearing. So it is being presented here again today for initial adoption. The Georgia Caregiver Registry is known within DCH and also externally as the Georgia Caregiver Portal. The purpose of the portal is to allow private family employers who are relatives or guardians of elderly persons located within Georgia to obtain employment eligibility determinations in the same manner as licensed facilities for current or prospective employees. The portal provides family employers with eligibility determinations in a similar manner as employees in licensed facilities such as nursing homes, assisted living communities, and home health agencies. The use of the caregiver portal is voluntary. There is a fee per background check to use the portal in the amount of $51.50. The caregiver portal is not to be used by licensed facilities. They have an existing portal of their own called the GCHEX system, or the Georgia Criminal History Check System. The DCH Background Investigations Unit is taking steps to create awareness of the portal. We have a webpage on our Office of Inspector General website dedicated solely to the caregiver portal. We have frequently asked questions posted on that site. We're developing webinars to spread awareness. And we're also working in conjunction with the DCH Communications Office, using the platforms that they typically use to spread awareness. The public hearing for this rule is scheduled for October the 13th at 10 a.m. via WebEx, and written comments are due by 5 p.m. on October the 15th. Final adoption is scheduled to be presented to the board on November the 11th, 2021. That's all I have, Commissioner Boyd. I'll take any questions.
Any questions or comments from the board, please? Hearing none, is there a motion for approval for initial adoption?
Trail will so move.
Mr. Trail has moved for initial adoption. Is there a second?
Russell Crutchfield, second.
Mr. Crutchfield has seconded. All in favor, say aye.
Aye.
Opposed? Abstaining? Hearing none, it is approved. Thank you for being here, Nigel.
Thank you, Chairman Boyd.
At this time, is there anyone that knows of any new business that should come before the board? Anyone have any further comments? Hearing none, Thank you for your participation and attending this morning. And with our next meeting will be October 14th at 10:30. Thank you all very much. Have a good day. Meeting adjourned.
Thank you.
Thank you.